Hey, Section 7. Hope everyone is doing well. Here we are for the Block 2 wrap-up. So I apologize for getting this out late. Like I said, I was in New York last week working on my posts from Brooklyn at our VRBO, and so hopefully they weren't too scattered. But this wrap-up finally got home, and this wrap-up is going to be just hopefully some high points of the article. Some of the things that I really feel like we can't talk. There's just so little time to talk about all the really good stuff that is available, and these articles kind of set a stage, if you will, for lots of kinds of discussion. And sometimes the discussion goes in the way I want it to, and sometimes it doesn't. And I try to make sure that we cover a lot of things by talking about different topics. But there's so many ways in which to go, and I'm going to do again my best to keep this short. But I really want to discuss some of this stuff. So basically, this Rowan article, shoulder pain versus conservative management of CSI. A couple of things come to mind when I read this. Certainly these cortisone injections can be helpful, but they also have problems. I know, unfortunately, the people that I see typically tend to be type 2 diabetics, and this is not great for them. These are not great options. Conservative management, physical therapy is a better option. Many factors affect outcomes. Oftentimes, we didn't even talk about this, but there continues to be a growing body of literature that looks at yellow flags. And I'm telling you, if people have a lot of stress and depression and anxiety and other things going on in their lives, these aren't as much going to matter, or the cortisone injection isn't going to matter as much. But they didn't control for that in the Rowan article, and that was, I brought up that to one or two people, I think, but something to think about whenever you're reading these things, because we're learning more and more and more that yellow flags drive outcomes. And if you control for those yellow flags, or those yellow flags are at least looked at, they can be a guide to how people perceive their pain and perceive their success. The whole diagnosis of impingement and tendinopathy is fraught with error. Our special tests tell us nothing. I shared with you, impingement happens all the time, both with symptomatic and asymptomatic people. That's why I get a little bit nervous about showing people an impinging shoulder, even using the term impingement, because I feel like it has a negative connotation that drives this fear that if I raise my arm that has pain every time I get pain, I'm impinging or pinching on something, whereas we know that asymptomatic people impinge all the time. And tendinopathy, we don't really know how to differentiate between these partial tears, tendinopathy, and what we may consider to be impingement. These are just fraught with error. That's why I think the McClure article is really a big deal. I think Lewis comments to that. I also shared with some people comments that Paula Ludwig, who I happen to work with at the University of Minnesota, who is also doing some research along these similar lines, that maybe we probably need to be categorizing these people, right? And not using special tests to guide treatment. Because special tests, again, aren't so special. Because remember, our diagnosis guides our treatment. And if our diagnoses are fraught with error because we don't have great things to categorize people, then how can our treatment be any better? Why can't we just call this shoulder pain? Why can't we just say that you have weakness or you have stiffness? Those are things that patients can control. I try to use terms that patients can control. If something's impinging, they have very little control over that. I guess if you couch it in the framework of exercise, and you can control impingement through exercise, well, perhaps. But again, I worry about the imagery, because when I tell my patient, yeah, you're just weak, that's all it is, they get that. They're like, oh, I can see that. This is really hard. It makes me tired. Or, oh, yeah, it's a little bit stiff. Big deal. Let's get rid of that stiffness and let's work on the weakness. And then, so adhesive capsulitis, we didn't really, I tried to talk about some of that because that wasn't really what was some of the questions, but best practice, injection, depending on irritability, and physical therapy. That's really kind of what best practice is considered right now. If they have high irritability, injection is a big deal. The research shows that is it really a capsular restriction? That's what I was taught. Some of the recent work by Holman would say that this has less to do with capsular restrictions and more to do with muscle guarding. Their study was very interesting, and that came out just in the last couple of months, so check it out. They even tweeted out a picture of a woman, one of their subjects who was anesthetized, and they basically were able. She had basically full range of motion of her shoulder when she was anesthetized. And so, is this really a capsular? Are we really stretching the capsule when we do the glenohumeral joint mobilizations, or are we providing some kind of an input to the nervous system that perhaps reduces the muscle guarding? I shared with some people an article that I really like that looks at both high velocity and low velocity joint mobilizations, and high velocity being grade 3, grade 4, and low being 1s and 2s. I used to be very aggressive with these patients, perhaps too aggressive depending on who you ask, and maybe didn't really make them any better, when in reality I could have used grades 1s and 2s and probably gotten the similar results. Or more recently, I tend to do a lot of upper limb tension testing, prepositioning them in upper limb tension positions. And, whether it's median nerve, the base 2 test, or the base 2A versus base 2B, and then doing some cervical side glides, doing some thoracic and scapular mobilizations. I do a lot of scapular mobilizations with my adhesive capsulitis patients, and then let them just kind of work on their range of motion on their own. But definitely treating around the area, and I find that I get really good results without nearly the pain, especially with those people who are really irritable. I work above and below in a lot of cases, and can send them home with just some basic nerve glide. So I would challenge the highly irritable patient, usually has some poor neurodynamics, and then talking to them with T&E, therapeutic neuroscience education. What is pain? What's going on? What do they have to look for? How can they take ownership of their pain? What is it that they can do to control this? These are all things I think that are really important, and things that we need to be thinking about in how we treat these people, because things are changing. Evidence-based medicine is you continuing to keep up with the literature, being aware of the Holman article, being aware of the Michler and McClure, and anything else that comes down the pike, like Lewis. Lewis had a 2018 article that went even further that I shared with a couple of people. Evidence-based medicine is not somebody spoon-feeding you these articles. So I challenge you to continue to look for research, have something established, so that information is being pushed toward you. Every month I get articles pushed toward me. On Twitter, I follow these people. I follow people like Holman. I follow people like Missioner McClure. Unfortunately, Paula Ludwig does not have a Twitter account. But Chris Littlewood, who also did a great article on, who does great work on shoulder tendinopathy. And that's a whole nother article that I just love that I probably won't have time to go into, but Littlewood does some really good stuff on Twitter. You stay right there, right? What you learn today will not be true tomorrow, right? And so remember that you need to continue to keep up these yellow flags that are coming up with any kind of musculoskeletal pain. This is an evolving thing. It's your job, your responsibility to be caught up, to keep up with this. So I challenge you to do so. And again, these are just some highlights. I could go on. That Littlewood article I'd really like to go into. So looking ahead, we're going to dive into the elbow, wrist, and hand, and neurodynamics. Some people have already started to talk about these things. Because with our case study, people are, that was one of the things that people really seem to understand irritability, which is really good, because I think that's huge. The sins seem to all be right there. I would challenge you guys. One of the things that we want to do in our response posts when we're responding to a colleague, share some of your clinical experience. Share how the literature has either helped you go further, or maybe questioned what you do. Combine those two things. Don't just ask a question just to ask a question. Ask a question with some thoughtfulness to it that helps not only give some background, engage. It helps engage people. That's how we continue to converse. Right. And so some groups did really well this week of digging in. Other groups really struggled to engage. And so we're going to be breaking up the groups. It is mid course, if you will. We've made it through the first 2 blocks. And so I'll be sending out new groups for everyone to be assigned to. I will continue to monitor. In this time, for block 3, I will be taking Alpha, Bravo, and Delta, and Trent will take Charlie. Feedback is coming. I've almost got it all done. I'll be sending it out either tonight or tomorrow. The biggest issues I have, people aren't engaging like they need to be, so that we can create good conversation and continue to go get some literature that supports what you do or supports the ideas behind your thought process. If you have any questions about any of this, obviously feel free to contact me. I continue to enjoy the dialogue that I get with people, so continue to engage me, ask me questions, challenge me. Let's continue to work toward a better understanding of what our profession is trying to do. Don't hold back, and feel free to push back on me if you feel like, yeah, you know what, he's full of it, and I want to challenge him, because I enjoy that as well. So enjoy the rest of your weekend, and then I will see you as we get into Block 3, and then look for my feedback coming soon. Take good care.